So far, our discussion of cardiac dysfunction has centered on congestive heart failure. It involved an initial insult to the myocardium, whether it's a blocked coronary artery causing myocardial ischemia or a faulty valve sending a bunch of fluid and pressure into the chamber. All of a sudden, the heart can't keep up with the load it's given, and it undergoes hypertrophy, either eccentric or concentric, a last-ditch effort to boost output. Well, what if the heart doesn't wait for that initial increase in pressure? What if the heart muscle itself is already misshapen? That's cardiomyopathy. You see, instead of a response to increased load in the chamber, structural changes to the myocardium occur because of other intrinsic pathologies. And, as we'll soon illustrate, there are a ton of disorders that can affect the heart muscle directly to cause cardiomyopathy. Luckily for us, it all boils down to three distinct pathologic patterns: dilated, restrictive, and hypertrophic. We'll focus on dilated and restrictive cardiomyopathy in this sketch and save hypertrophic cardiomyopathy for our next video. Now, I know what you're thinking. Where are we? The idyllic green hills? That sonorous humming of bagpipes off in the distance? The faint smell of national pride in knee-high socks. And haggis, if I'm not mistaken, lingering in the air. Yep, we're in Scotland, just in time for the annual Scottish Highland Games. New event this year, by the way. A good old-fashioned sack race. See that big, floppy, heart-shaped sack? Let it remind you of dilated cardiomyopathy. The name says it all. The heart is big and floppy, and has lost its ability to forcefully contract. Dilated cardiomyopathy is the most common form of cardiomyopathy, making up about 90% of cases. The weird thing is, most of the time, we don't even know what causes it, and the patient is simply diagnosed with idiopathic disease. It's kind of like our idiopathic idiot over here. He just doesn't really know what's going on, and he could be better at sack racing. There are, however, several identifiable causes of dilated cardiomyopathy. The most common involves inflammation of the myocardium, or myocarditis, usually caused by a viral infection. And though a lot of the time, no active inflammation is evident once the cardiomyopathy reaches end stage, that initial flame of inflammation is enough to set off a chain reaction within the myocardium, leading to progressive dilation, contractile dysfunction, and eventually heart failure. And that's the key endpoint to keep in mind here: systolic heart failure, as depicted by our recurring floppy failing heart balloon. Remember, when we want to emphasize systolic dysfunction specifically, look for that dysfunctional systolic spray. Dilated cardiomyopathy leads to reduced contractile function, often affecting both sides of the heart. So you should expect to see the typical findings of heart failure with reduced ejection fraction, dyspnea, fatigue, JVD, bibasilar crackles, and peripheral edema. All right, back to the various etiologies that initially set off this myocardial dysfunction. The big one is viral myocarditis. When you hear the term viral myocarditis, you should immediately think of Coxsackie virus type B. Remember that floppy dilated sack of birdseed underneath our Coxsackie cockatoo? It was way back in that coronavirus video. The presence of the virus and the lymphocytes that follow disrupt the normal architecture of the cardiomyocytes, resulting in diminished contraction. Other enteroviruses may be involved as well, such as parvo and adenovirus. On the test, the question stem will involve a 30-ish-year-old patient with an episode of fever, runny nose, and myalgias that he experienced last week. Sounds like a viral infection to me. And now he's presenting with acute heart failure. He's got dyspnea on exertion, lower extremity edema, lung crackles. This guy's way too young for heart failure. I'm putting my money on viral myocarditis leading to dilated cardiomyopathy. Another highly tested pathogen to remember is Trypanosoma cruzi, the protozoan responsible for Chagas disease. You may remember our sketchy micro video, where Che Guevara is filling up at the gas station. That Chagas disease is associated with dilated cardiomyopathy, megacolon, and megaesophagus. Everything's just kinda dilated. Sometimes you can even see the trypanosomes on histology within the cardiac myocytes. Alright, after infectious myocarditis, genetic mutations represent the second most common cause of dilated cardiomyopathy, accounting for about 25% of cases with an identifiable etiology. Most of the time, it's an autosomal dominant mutation, hence our recurring autosomal dominant domino, acting as a clasp here, holding his flag together. We've even incorporated a genetic family tree design. See, the genes involved are normally responsible for encoding proteins that become a part of the cardiac cytoskeleton, the sarcomere, or in the architecture connecting the two. So, notice the cytoskeletal theme of that dilated sac. The specific proteins involved in these mutations are not highly tested, but include alpha cardiac actin, desmin, and the nuclear lamins A and C. Dilated cardiomyopathy can also follow a pattern of X-linked inheritance, though more rarely. For X-linked, just think of the big white X that adorns the national flag of Scotland. Take a close look, and you'll notice it's incorporated into the crests of Clan Becker, as well as their rival, Clan Duchenne. Every year with these two. Frickin' Duchenne especially. Look, you guys, where are Jock Tamsin's bounds? Jock Tamsin was, never mind. These X-linked mutations occur in the gene that codes for dystrophin, important to the pathogenesis of both Duchenne and Becker muscular dystrophy. Yep, always trying to outdo each other. They even have the same mantra written on their crest: destroy, which should remind you of dystrophin, a protein that helps connect the intracellular cytoskeleton to the extracellular matrix of the myocyte, which is important for proper contraction. Dysfunctional dystrophin means diminished contractility, and eventually a floppy failing heart. Dilated cardiomyopathy is, in fact, the primary cause of death in patients with Duchenne muscular dystrophy. Okay, let's move on to toxic exposures, a fairly common cause of dilated cardiomyopathy. One of the most frequently mentioned cardiotoxic substances are anthracyclines. Anthracyclines are a class of chemotherapeutics that includes, among many other drugs, doxorubicin and daunorubicin. In this sketch, these drugs will be embodied by this box of rubies here, the grand prize of the entire tournament. Cardiotoxicity from anthracyclines is related to their mechanism of action. Remember all those free radical oxidizing bubbles floating around in our underwater doxorubicin ruby sketch back in Sketchy Farm? Well, the same free radicals responsible for killing cancer cells are also responsible for myocardial cell damage, leading to patchy fibrosis and what's called myofibrillar dropout. And it looks like we have our winner. That celebratory drinking horn represents alcohol, which can also be cardiotoxic. You see, alcohol and its primary metabolite, acetaldehyde, are directly toxic to cardiac myocytes when present in significant concentrations. What the? Soon with a heat needle and a burning thread. He's cheating. See his foot bursting through that heart sac? That's definitely some direct myocyte toxicity. Alcohol can also cause indirect toxicity to heart muscles over time. Because alcohol abuse is associated with malnutrition, you might see a vitamin deficiency or two. Thiamine, or B1 deficiency, for example, can cause Wernicke-Korsakoff syndrome and beriberi. One of the two manifestations of beriberi, known as wet beriberi, is associated with progressive heart chamber dilation, interstitial myocardial edema, and eventually myocardial fibrosis. Whenever we mention beriberi, just think of these vitamin B1 blueberry berries. Though we don't yet fully understand the underlying cause of peripartum cardiomyopathy, it represents a well-established subset of dilated cardiomyopathy. It's most often seen late in pregnancy or soon after childbirth, even weeks or months later. Look for an acute decline in exercise tolerance. Echocardiography confirms the diagnosis. You'll see those dilated heart chambers. And although there's no treatment for the underlying cause, the fortunate part is that about 50% of these patients will have a spontaneous recovery in heart function. The relationship between iron overload and cardiomyopathy is a bit complicated because it can cause either dilated or restrictive cardiomyopathy. What's important to remember is that excess iron gets deposited in the myocardium, messing up contractility. Just think of this excessive iron weight here, holding back that myocardium, stretching it out. Excess iron results in the production of reactive oxygen species. And just like with anthracyclines, you've got direct damage to the cardiomyocytes. The cause of iron overload can either be inherited, as in hereditary hemochromatosis, or the result of frequent blood transfusions. On histology, intracellular iron deposits can be detected with Prussian blue staining, hence the outrageously patriotic Prussian blue face paint, or WOAD, as it's called in Scotland. Check out our hemochromatosis video for a more in-depth discussion of the presentation and diagnosis of iron overload syndromes. Alright, as I mentioned before, dilated cardiomyopathy involves an initial insult to the myocardium that causes contractile dysfunction. It's usually not diagnosed until the cardiomyopathy has reached end stage, and what you end up with is systolic heart failure and its related symptoms, dyspnea, JDD, bibasilar crackles. On cardiac examination, you may hear an S3, an important sign of ventricular dysfunction. Hear it? It's caused by all that blood sloshing into that floppy ventricle, embodied, as usual, by a recurring S3 slushy. With enough ventricular dilation, the mitral and tricuspid valves stretch out as well. So as the scrawny spectator regurges all over himself, listen for some related systolic regurg murmurs. And anytime you have contractile dysfunction leading to pathologically dilated chambers, you can start to get abnormal blood flow and stasis, leading to an increased risk of developing mural thrombi. It's kind of like these thrombotic bird's nests that have adhered to the mural brick wall in the back. Watch out for thromboemboli, which can find their way to the brain and cause embolic stroke, just like these ischemic bird poops, right on that cerebral circulation there. In the evaluation of a patient with new onset CHF symptoms, you might get a chest x-ray, which, in the case of dilated cardiomyopathy, would show an enlarged cardiac silhouette. The definitive diagnosis, however, is made by echocardiogram, embodied, as usual, by our recurring ultrasound bullhorn. On echo, look for an enlarged heart with dilation of all four chambers. You might see some wall thinning as well, but in reality, the ventricular thickness can be variable. All right, we made it. On to restrictive cardiomyopathy, a group of disorders where something abnormal has infiltrated the heart muscle fibers and impairs its ability to stretch. At Sketchy, whenever we want to convey a heart that just doesn't want to stretch, we draw a heart in a net. You know, the Highland Games have been around for centuries, and when a sporting event has been around for that long, you can always count on one thing: burly dudes throwing around really heavy stuff. As the ref dodges that stray shot put, notice he's dropping the official Highland Games rulebook. At the same time, emphasizing the decreased ventricular compliance seen in restrictive cardiomyopathy. In other words, as the heart grows stiffer, restrictive cardiomyopathies will lead to diastolic heart failure. As always, we've included our deflated heart failure balloon. And remember, when we want to emphasize diastolic heart failure specifically, look for that diastolic diamond. Unlike dilated cardiomyopathy, which leads to ejection problems, restrictive cardiomyopathy leads to filling problems. The ventricle is just too stiff and can't fill during diastole. This is represented here by this Highland lady as she struggles with those pint glasses. Definitely some filling issues going on there. So look out for those typical findings associated with diastolic dysfunction: dyspnea, bibasilar crackles, peripheral edema. On cardiac examination, you may hear an S4 sound. Hear it? It's caused by all that blood hitting that stiff, non-compliant ventricular wall, embodied, as usual, by our stiff wooden S4 chair. Jugular venous distension, or JVD, will pop up as well, in all senses of the phrase. Let that big blue distended jug remind you of distended jugular veins caused by impeded venous return. Remember, the heart just doesn't want to fill. The pulsations in that distended jugular vein also show what's called a prominent Y descent, represented by this Y-shaped glass descending to the ground next to our dilated jug. Remember, in the jugular venous pressure waveform, the pressure dips down twice. The first X descent corresponds with the atrium relaxing. The second Y descent corresponds with the atrium emptying when the tricuspid valve opens. Well, you can imagine if the wall of the ventricle is really stiff, it springs back quickly to fill with blood. It kind of sucks that jugular blood down with it. This causes a big dip, or prominent Y descent in that jugular vein. Taking a deep breath usually pulls blood into the pulmonary circuit, but not if your heart is restricted and can't fill. So a deep breath will actually cause more blood to back up, increasing JVD. That's called Kussmaul sign, and it's represented by the Scotsman here, elevating a jugular jug as he takes a big whiff of those Kussmaul cookies. Alright, let's finish up the sketch with a brief outline of the numerous causes of restrictive cardiomyopathy. Keep in mind that, though we are highlighting the cardiac dysfunction associated with each etiology, it's usually just one part of a more widespread systemic disease. So as we go through the separate disorders, rest assured that each will have a more in-depth video later in the course. Now I want you to imagine some kind of molecule infiltrating that myocardium and making it stiff. Let's start with amyloidosis, a systemic disorder that involves the abnormal deposition of insoluble proteins throughout the body. Amyloid will be embodied by Amy, our amyloid armored lady. Cardiac amyloidosis results from abnormal extracellular deposition of insoluble proteins, such as transthyretin or amyloid light chains. She's even donned her chainmail tunic, made up of an infiltrative collection of light chains. For now, I just want you to focus on Amy's battle-worn heart shield. It should remind you of the typical endomyocardial biopsy findings associated with cardiac amyloidosis. On H&E stain, you'll see normal myocardial cells with kind of splotchy areas infiltrated by acellular pink material. The next infiltrative disorder to mention is sarcoidosis. You know, the Highland Games is only once a year. To make ends meet during the off-season, the space is rented out to the local youth soccer league. Hence the sarcoidosis soccer balls in the back of the net here. Sarcoidosis is a non-caseating granulomatous disorder of unknown etiology that can involve any organ in the body. And when it shows up in the heart, it can cause all kinds of effects, including restrictive or dilated cardiomyopathy, conduction defects, arrhythmias, and even sudden cardiac death. It's the histology that's key here. Microscopic examination of the myocardium will reveal the presence of non-caseating granulomas containing giant cells. The purple panels on the soccer balls even look like all those nuclei found in a multinucleated giant cell. Let's see here. A big sweaty guy, hurling a ridiculously huge iron weight. Yep, looks like we're bringing back hemochromatosis. The cardiomyopathy from iron overload syndromes usually manifests as a dilated cardiomyopathy, but it can be restrictive as well. And remember that Prussian blue face paint. On histology, intracellular iron deposits can be detected with Prussian blue staining. If you catch it early, cardiomyopathy secondary to hemochromatosis is actually reversible with treatment. It involves getting rid of all that iron in the body with phlebotomy and chelating agents. Alright, what else? So many muscles. Must lift heavy things. Garbage truck! Just when you thought these Highland Games couldn't get any more exciting, it's time to bring in the lysosomal storage diseases, because a number of them can result in restrictive cardiomyopathy. Think of a lysosome as a garbage truck, breaking down the cell's garbage. However, when an enzyme is missing inside the lysosome, all that garbage starts to accumulate in organs throughout the body. Sometimes that means the heart as well. In Gaucher's disease, for example, it's those pesky cerebrosides. In Hurler's syndrome, mucopolysaccharides accumulate in the myocardial interstitium as well as the cardiac valves and coronary arteries. In Fabry's disease, now you're hoarding a bunch of extra glycolipids. All of these disorders are associated with a range of systemic symptoms as well, and each will be covered in depth in our developmental disorders unit. Alright, for the last few causes of restrictive cardiomyopathy, instead of molecules accumulating inside the cardiomyocyte, I want you to think of myocardial fibrosis, resulting in a stiff, non-compliant ventricle. It can occur in isolation or as a part of a more widespread systemic disease. One such example is scleroderma. Sometimes scleroderma affects only the skin and subadjacent tissues. Just think of the singed, sclerosed dermis of our recurring scleroderma dragon. When scleroderma is associated with internal organ involvement, the disease is termed systemic sclerosis. And if the heart is involved, it's all kinds of bad. It leads to pericarditis, heart failure, myocardial infarction, arrhythmias, and myocardial fibrosis. Next, let's sketch in our recurring radiation symbol. We'll put it on a shield, knocked aside by that amyloid armored lady. Irradiation to the chest will often cause unintended damage to the surrounding tissues, sometimes even fibrosis of the myocardium, which can lead to a restrictive cardiomyopathy. And no Highland games are complete without the caber toss. You know, that game where you toss a caber. It's a large tapered pole, and in this sketch, that fibrous heart-shaped projectile, held close to the chest there, will be our symbol for endomyocardial fibrosis. It's a disease that's characterized by fibrosis of the apical endocardium of the ventricles. Endomyocardial fibrosis is probably the most common form of restrictive cardiomyopathy worldwide. The disease has the highest prevalence in tropical regions such as Uganda, Nigeria, Ivory Coast, South India, and Brazil. The cause of all this endomyocardial fibrosis? It's largely unknown. Endomyocardial fibroelastosis is a bit different. See that elastic band wrapped around our fledgling Scotsman's chest, holding up that oversized kilt? That's fibroelastosis, and it's characterized by diffuse thickening of the left ventricular endocardium secondary to proliferation of fibrous and elastic tissue. It primarily occurs in infants during the first year of life and is often seen in conjunction with congenital heart disease. All right, time to sum up these Highlander hijinks. With dilated cardiomyopathy, expect systolic dysfunction, as evoked by that systolic spray. With restrictive cardiomyopathy, you'll eventually see diastolic dysfunction. That means ventricular filling problems, hence the filling issues happening next to the net on the right. Dilated cardiomyopathy is usually idiopathic, and viral infections play a large role as well. About 25% of identifiable causes are genetic, involving mutations in cytoskeletal proteins. Just remember that autosomal dominant domino guy in that cytoskeletal sac. He's closely pursued by Duchenne and Becker muscular dystrophy, which are less common X-linked disorders that involve dysfunctional dystrophin, a protein important for anchoring myocardial fibers. Round that out with hemochromatosis, pregnancy, alcohol, and anthracycline-related cardiomyopathy, and you've got yourself a heated sac race. That could have been said better. For restrictive, think of stuff accumulating in that ventricular wall, like amyloid, iron, or lysosomal byproducts. There are a few fibrotic conditions as well, such as systemic sclerosis and endomyocardial fibrosis. Next up, hypertrophic cardiomyopathy, because the festivities have only just begun. Pull up your socks and put on your sporran, because it's time for some hypertrophic bagpipes.